Well, good evening, everyone. Thank you very much for being here. I'm Neil Lane, University Professor and Senior Fellow of the James A. Baker III Institute here at Rice University. We want to thank you all for taking time out of very busy lives, schedules, to be here to hear about what we think is one of the most important issues faced by the state of Texas, the lack of access to health care and health insurance by many of the people living in our state. Baker Institute, of course, is very pleased to host this event today. Now, in case you're not familiar with the Baker Institute, let me say a word about it. It was founded in 1993 and is led by founding director, Ambassador Edward Jurigian, who's sitting right up here in the front. Ed, raise your hand. People want to corral you, write checks or whatever toward the latter part of the day. And by honorary chair, former Secretary of State, James Baker. The mission of the Baker Institute for Public Policy is to bridge the gap between the theory and practice of public policy. And in the past 13 years, we welcome distinguished speakers from around the world, including Nelson Mandela, Simon Perez, Madeleine Albright, and many others to discuss some of the world's greatest problems and most vexing challenges. The Baker Institute has a long history of addressing health and science policy. For many years, Dr. Alvin Tarloff led the Baker Institute Texas program in society and health until his retirement in 2005. In 2004, the Baker Institute established a new program in health economics, led by Dr. Vivian Ho, the Baker Institute Chair of Health Economics, who was also an associate professor in the Department of Medicine at Baylor College of Medicine. We're very fortunate that Dr. Ho will be with us on our distinguished panel a little bit later in the program. My personal involvement in the Baker Institute is through the Science and Technology program. The goal of the program is to bring together scientists, policymakers, business and community leaders to stimulate discussion over important issues such as our theme today, access to health care and health insurance in Texas. The Baker Institute Science and Technology Policy Program was launched in 2003, and in the past few years we've sponsored several dynamic speakers and programs, including an address on women in science by Dr. Sally Ride, former astronaut, a talk on energy policy by Mr. John Podesta, who was President Clinton's chief of staff, a 2003 conference on the role of science in public policy, and two conferences on human embryonic stem cell research policy, and have participated in space policy activities in partnership with Mr. George Abbey, former director of the Johnson Space Center, who's also a senior fellow of the Institute, and Amy Jaffe, a fellow with the Institute who directs the Energy Forum. Now, some of you may be wondering, at least I think you would, how I, a simple physicist by trade, got involved in this very complex and important issue. Well, I want to tell you, 2 years ago, I got a phone call from my colleague, Dr. Ken Shine, whom you'll hear from in a minute, the Executive Vice Chancellor for Health Affairs at the University of Texas System, to chair the task force. My first thought was, why me? Thank you for the call, but why me? In my career, I've worked on subatomic particles. I've done a little work on science policy in the past 10 years, but I have never dealt with issues of health care or anything as complex as health care. Besides the occasional visit to the doctor, I also have some insurance. I know it's expensive, and if you don't have it, you have trouble getting health care. So I have that kind of on-the-ground experience that many of you do, but otherwise I don't know anything about it. And Ken's response was, that's exactly why you would be perfect for this job. So that, much as I thought it was not a good idea, I was delighted to be involved, and I've learned an enormous amount. Although he didn't say it, I think he felt physicists are also a lot like people, and so we might as well bring one into the community. So over the past 2 years, it has been a genuine privilege for me to chair a very diverse 19-member task force of Texans, representing the best of the medical and health policy communities, who have volunteered their time to understand, to analyze, and to develop policy recommendations aimed at increasing affordable access to health care for the uninsured and underinsured in Texas, and at the same time to relieve the financial and other burdens that the lack of such access has placed on this state and all of us fortunate enough to live here. While the task force members have considerable experience and expertise in health and medicine, they do not represent any organization or any political party. all of us served as individuals and concerned citizens. Now, through a process of information gathering, research and analysis, including commissioned research papers and hearings involving many experts and concerned individuals, and after extensive discussions, I might emphasize, we've all learned a great deal more about this subject than we perhaps knew coming in. And personally, I've been impressed with how big this problem really is and the challenges of dealing with it. I've also been alarmed at the prospect of what is likely to happen to our state if we don't find a solution pretty fast. Although I still do not consider myself an expert by any means, I know there are things that we as Texans can do to help expand access to health care and health insurance throughout the state. It is striking and disturbing, I think, that the current fraction of Texans without insurance is 25%. That is in 2004. The task force believes this is untenable. Not only is this figure much greater than the national average, which is just over 15%, but the growth projections made by state demographer Steve Murdoch indicate that the number of uninsured Texans will grow rapidly over the next few years in terms of both percentage and absolute numbers. Caring for the uninsured places extraordinary burdens on hospitals that serve them, on the trauma system, on our emergency rooms, and our other social services, and as a result, it affects all Texans. Based on the work of the task force, we have produced a report titled Code Red, and that's why it's red, in case you had not noticed, the critical condition of the health of Texas. We chose this title because we believe that the patient, namely the health of Texas, is in critical condition, and that immediate intervention is required to stabilize this patient and to offset impending worsening of the patient's condition. In plain language, Texas is getting sick, and we would like to keep it from getting much sicker. We believe everyone in the state would like that as well. The report is intentionally fact-based, and it was peer-reviewed by independent experts who were not on the panel before it was released. This is the standard practice which has worked very well for studies and reports of the National Academies of Science Engineering and the Institute of Medicine, Washington. We greatly appreciate the careful reading and critical comments of our reviewers, whose names I do not know. This evening, we're privileged to hear from several members of the task force, as well as leading healthcare advocates and experts from the Houston community. Dr. John Stobo, the vice chair of the task force, will start the program with a review of the task force findings and recommendations. Jack Stobo is the president, I think you know, of the University of Texas Medical Branch at Galveston. He holds an MD from the University of Vermont Medical School and has had a distinguished career, including appointments at the National Institutes of Health, the Mayo Clinic, the University of California, San Francisco, and Johns Hopkins. During his career, he was investigator of the Howard Hughes Medical Institute and was the chairman and CEO of Johns Hopkins Healthcare, an organization created to address challenges in managed care on behalf of Johns Hopkins Medicine. Jack Stobo is a man I greatly admire, and I have learned a lot from these past 2 years. He is an expert on healthcare, so please join me in welcoming Dr. Stobo today as he talks to us about the findings and recommendations from the report, Code Red, the Critical Condition of Healthcare in Texas.
Thank you very much, Neil. It was indeed a pleasure to work with you as chair of this very hard-working committee. As you can tell from the picture here, the motion behind it, this is not an issue we think that's going to come to Texas. We think it's an issue that's here, a problem that's here, and one that needs to be addressed quickly. Because what is at stake is not just the health of Texas, but the health environment that affects everybody in this room, whether they have health insurance or not, and hopefully the reasons for that will become plain tonight. What I'm going to do is to divide my presentation into 3 areas. First of all, I'm going to talk a little bit about the background of the issue that led to the formation of the committee, to talk a little bit about the background of the committee and the report, and then to present the 10 recommendations that are in the report. As Dr. Lane said, there is a summary which is available in its final printing, and then there is the body of the work of the committee, and the appendices, which contain much valuable data that was used by the committee to form its recommendations. I want to thank the staff for putting together the PowerPoint for this presentation. This is the first public presentation of the report. We had a press briefing in this institute this morning, and today is the first day that the report has been made public. Let me talk a little bit about the background. As Dr. Lane indicated, roughly 15% of citizens in the United States lack health insurance, roughly 46 million Americans. That contrasts to 25% in Texas, 5.6 million individuals, or 1 out of every 4 individuals lacked health insurance in 2004. Now, this doesn't take into account the number of individuals that were underinsured, that is, didn't have satisfactory health insurance. These are individuals who lacked health insurance. And the problem will grow worse as one looks at the demographics of Texas in terms of the growing number of individuals who occupy the lower socioeconomic status and therefore will probably not have the means to purchase health insurance. And the other major factor that's going to make this situation worse is a rising cost of health care, increasing at 2 to 3 to 4 times the consumer price index or the regular rate of inflation each year. With double-digit yearly increases in the cost of health insurance, the number of uninsured is only going to increase, not only in Texas, but indeed in the nation. Now, who are the uninsured? 79% of the uninsured live in a household in which there is at least one individual who is working. So they are members of a working household. Now, 75% of the employers in the state of Texas are small businesses. That is, businesses that have 50 or fewer employees. Only 37 of those businesses offer health insurance, and only 1 out of 3 individuals who are working for those employers purchase health insurance. So for 75% of the businesses in the state of Texas, only 10% of the individuals working for those, in fact, have health insurance through their employer. For a family of 4, the federal poverty line is at $20,000 a year, roughly, actually it's a little below that. This is the federal poverty level, 100% of the federal poverty level in the United States. The average cost of health insurance for that family of 4 is roughly $9,000 to $10,000. So half of the income for a family of 4 that is at 100% of the federal poverty level in the United States, half of that income would have to go for health insurance if they were able to buy it. Now, many adults do not qualify for Medicaid in Texas because they have too much income, even though they sorely need Medicaid. Medical indigence in Texas is currently defined as those living at less than 21% of the federal poverty level, less than $1,700 a year for a single adult. So in order to be covered by certain, particularly county-based indigent care health plans, if you're a single individual, you have to be making $1,700 a year or less, or for a family of 4, roughly that would be about $6,000 or $7,000 a year. Very, very low yearly income. The state's children's health insurance covers the children covered by the state's CHIP program. Those children, it covers children who make or are at 200% of the federal poverty line. That is, that family makes 200%, but the parents of those children are not covered by the program. Now, it's often been said, so what? If you don't have health insurance, you go to an emergency room and you get your health care, or you go to some free clinic and you get your health care. So it's really not a health consequence to these individuals who don't have health insurance. Well, indeed, that is not the case. Study after study has shown that individuals who don't have health insurance have poorer health than those that do have health insurance. Lack of health insurance is a risk factor for having poor health. Individuals who don't have health insurance don't visit the doctors often as they should. When they get a prescription for medication, they can't afford to fill that prescription. As I say, they get their care mainly through emergency rooms. They fragment a way to get health care, a very costly way to get health care. And if you're uninsured and admitted to a hospital, your chances of dying during that hospitalization are 4-fold greater than those who have health insurance and are admitted to the hospital. Poor health status interferes with the education and work, and we'll show or talk subsequently about the inexorable link between poor health status or health status and education. There's damage done to community resources such as hospitals, emergency rooms, level 1 trauma units. Family disruptions, including bankruptcy. The number one cause of personal bankruptcy in the United States is related to costs related to health care. Higher health care costs are borne by those who do have health insurance. The calculation is roughly 20% of what you pay for health care costs is because of the number of uninsured. The rising tax burdens, a less attractive business environment. So there clearly are consequences related to the entire economy, to the entire educational process, to the entire state, with the number, having such a large number and percentage of uninsured individuals. Now, with this as a background, the task force came together about 2 years ago. The report is called Code Red, The Critical Condition of Healthcare in Texas. And it's a report by the Task Force on Access to Healthcare in Texas, Challenges of the Uninsured and the Underinsured. The task force is sponsored by the 10 major Texas academic health institutions: Baylor College of Medicine, Texas Tech, Texas A&M, North Texas, and the 6 health institutions that are part of the University of Texas system. And the 19 members include representatives from large and small employers, hospitals, medical schools, health policy experts, and community leaders. Indeed, a public-private partnership among the task force memberships. Now, let me make it clear that when the task force representatives came to the table as members of the task force, they came to the table as members of the task force, representing themselves as individuals, not representing the institutions for which they were part of. And there was tremendous unanimity among the task force. With the exception of one dissension on one recommendation, there was unanimity and unanimity among all the task force members on the recommendations. I'll just quickly go through the membership, 19 members. Dr. Lane chaired the committee. I had the privilege of being the vice chair. These are some of the members and some of the other members. The affiliations are all in the inside of this thin summary packet which you have access to. As Dr. Lane indicated, we met over a series of meetings over 2 years, commissioned several white papers and background pieces of material that are located in the appendix, and based on testimony from a variety of individuals throughout the state of Texas. Whenever we went to a community to have a meeting, and we went to different communities so we could have presentations from individuals in that community that either experienced the problem or were working to solve the problem. Based on that testimony, background papers, etc., the committee came up with its recommendations. Now, some of the findings, let me just say, the task force concluded that a solution to the challenge of the uninsured must arise out of a shared responsibility for the problem by a broad diversity of participants. No single entity, no single group of individuals, or no single individual can solve this problem. It's going to take a partnership from a variety of different sources to have an impact on the problem. Additional resources and the more efficient and effective uses of the resources will be required in order to provide appropriate services to the uninsured. Time and time again, we made the point that our recommendations have to include recommendations that address the rising cost of health care and a more effective use of resources to address the health needs of the residents of Texas. Some of our findings, as was indicated, the overall health status of Texas is poor, whether you use immunization rates, mammography rates, whatever parameter you want to use, low birth weights, etc. One concludes the health of Texas is poorer than other states in the nation. Texas has the highest proportion of uninsured individuals in the United States, and that's not for a single day, a single week, or a single year. In fact, if you look over a 3-year period, that's true. Strategies to control the cost of health insurance are needed. Health insurance, the cost of health insurance, as I indicated, rises at double-digit rates each year, more and more expensive, more and more difficult for individuals to purchase or for the employers to provide. Current trends in the delivery of health care will exacerbate the problem. We really need to re-engineer the health care delivery system. Emergency rooms provide an expensive, episodic fragmented way of providing care. Some Texas communities are indeed making great strides to address this issue. We need to expand ambulatory services. The continuing rise in Medicare expenditures in the state of Texas, and I would submit in almost every state in the nation, are unsustainable, and this issue has to be addressed. A key finding is we clearly have documented the state of Texas has not taken full advantage of federal matching funds, so-called Medicaid drawdown, where dollars associated with the state Medicaid program bring in multiples in terms of their ability to attract federal dollars. The current county-based approach to health care in Texas is inadequate and inequitable, and we'll talk about this. There's a significant shortage of healthcare professionals in Texas. Educational attainment and health are inexorably linked. Care of people with mental illness remains a major unsolved problem for Texas. The solution to adequate access to health care for the uninsured and underinsured is a shared responsibility, as we've said and will say time and time again. Now, what are some of the specific recommendations? Let me go through this. And for each recommendation, there's 1, 2, 3, and sometimes more sub-recommendations with details in terms of what we think needs to be done to address the sub-recommendations and the overall larger recommendation. And there are 10 of these recommendations. The first is Texas should adopt a principle that all individuals living in Texas should have access to adequate levels of health care, and make some comments about what that means in terms of access and what we mean by adequate levels of health care. Recommendation number 2, Texas should provide more adequate resources and aggressively seek more efficient and effective methods to support health care to the indigent and uninsured with the goal of reducing rising health care costs. If we simply ask for more resources, more federal matching money, that by itself isn't sufficient. And the committee felt it would have abdicated its responsibility if that's all it said. We go on to say that we need to actively address issues related to rising cost of health care, the more effective and efficient use of health care resources, the use of clinical best practices, outcomes-based, evidence-based research, health care delivery, etc. Also in this inherent in this recommendation is the fact that there are opportunities for the state through the Medicaid drawdown to more effectively access federal matching monies that are appropriately, can be appropriately accessed. A quality assurance fee, called a provider tax in some states of 3%, should be assessed on revenues of all hospitals and freestanding surgical centers in order to obtain a federal match to enhance overall finances for provider reimbursement and enhancement of the quality and efficiency of health care to the uninsured. Now, at first blush, you might say, well, wait a minute, this is going after the wrong people. These are the people that are providing health care. Why would you want to tax them? Well, let me go on to try to explain. First of all, we're not the only state to suggest this. 35 other states have quality assurance fees. All classes of providers will be impacted, hospitals and surgery centers. Now, at 3%, it will produce $1.2 billion in fees. Now, if that's put into the Medicaid pool, then that $1.2 million is available for a 1.5 to 1 federal match, bringing in an additional $1.8 billion that could be used to address the problems of the uninsured. So, in fact, that money then can be used to go back and help some of these providers provide indigent health care so that they don't have to use other monies that they're presently using, which could be more appropriately used to do other things to provide indigent health care. So this fee will allow us to have a positive impact on the provision of indigent health care in the state of Texas. Through the Medicaid program, you could reimburse hospitals that are providing significant amount of indigent health care at Medicaid rates. You could also use it to generate funds for electronic health records, increase graduate medical education funding to address other problems pointed out by the committee, increase ambulatory care and disease management, and all facilities, and support all facilities that contribute to the care of the uninsured. So this can go a long way to addressing issues related to the uninsured. Recommendation number 4, the state should significantly increase its capacity and commitment to conduct experiments in healthcare delivery and funding, and we provide a series of examples. Other states are doing this. There are experiments and initiatives in Massachusetts, Maryland, and several other states. And we don't know what will work. The committee didn't say this is the only thing that will work in Houston, Austin, El Paso, whatever. But it said we need localities to do experiments and demonstration projects so we can say we have documented that this program works, that this program doesn't work. And there are some obstacles to doing this, but we think there should be greater emphasis on the development of some legitimate demonstrations and projects and experiments. The concept of virtual care coordination for the uninsured, including these patients in a structured system of care, should be developed by local communities and by Texas Health and Human Services Commission. The health care to this population right now is fragmented. Sometimes it's in a community clinic, sometimes it's a federally qualified community clinic, sometimes it's in an emergency room. If they go from an emergency room to a federal qualified health clinic, the medical record doesn't go along with them. There are duplications of tests, reordering of medicines, etc. We think an electronic medical record will go a long way. A portable electronic medical record will go a long way to increasing continuity of care. And we need to have a virtual system to seamlessly provide accessible, high-quality health care to this population. Recommendation 6, healthcare institutions and other providers must contribute to increasing community-based ambulatory care, which includes integrating the latest developments in disease management and other cost-effective models of healthcare delivery that seek to improve the quality of healthcare while decreasing the cost of healthcare. It's a fact. 80% of the healthcare costs go to take care of 10% of the people. And so there clearly are diseases and disorders that cost a lot in terms of providing healthcare, take a lot of resources, and there are ways to address that issue to provide more care in the community, more care in the ambulatory, lower cost settings, not in emergency rooms. Texas must increase investment in the education and training of health professionals who provide significant amounts of care to the uninsured and underinsured, irrespective of what group of health professionals you look at, whether it be allied health professionals, whether they be nurses, whether they be physicians. The number of health professionals per 100,000 in the state of Texas is below the national mean. These individuals play a very important role in providing health care to the uninsured, and we need to increase the number of health professionals in the state of Texas, and we provide specific recommendations in terms of graduate medical education, nursing programs, etc. The task force recommends the implementation of an integrated approach to school health, including an emphasis on nutrition, exercise, dental health, and disease management of such problems as asthma, and not included in here in the specific recommendation, but talked about in the report, are things like obesity. And the major problem that poses for children, and a problem that can be approached through schools, in school-based clinics. Academic health institutions, state and local governments, and communities, foundations, the private sector should support the development of health science research programs to study cost of effective health care and other characteristics of a high quality and efficient health care system. We need to do more research on what works and what doesn't work. And when we find that there is good evidence that supports what does work, then use that as a model. And finally, Texas should adequately invest in public health programs, including research and community health at the state and local level. As a group, we concluded that now is the time, not tomorrow or next week, but now is the time for Texas to take bold steps, like other states are taking, to address the problems associated with the lack of health insurance coverage and health care access in the state, and to protect and ensure the economic vitality and health of the state. And let me just emphasize that the problems of the uninsured just don't affect the uninsured. They just don't affect that group as a group of individuals, but it affects the health problems of the insured. If the uninsured go to emergency rooms, result in crowding of the emergency rooms, it makes it more difficult for the insured to get access to emergency rooms. If the cost of providing health care to the uninsured adds 20% onto the cost of the health insurance premium that insured pay, that affects that population. And the high number of uninsured has an impact on economic development. the desire of employers to locate into the state of Texas, the health of their workers, etc. So this is a problem that goes beyond, in terms of its effect, the indigent, those that don't have insurance. It affects the whole state. Now we do have a website, and we'll have a report website that will be made available to those who want to access. This report will be made available to those who want it. It is a responsibility now of the task force to disseminate this report, to be available to comment on the report as individuals, not as task force members, but as individuals, and to work with others in the state to implement to educate the state about the recommendations and to assist in any way they can as individuals in the implementation of the recommendations. I want to thank you for being here tonight to come and hear a discussion of this very important issue. And I'll stop now and be glad to answer some questions. Want to take questions now or go on with the panel? Dr. Lane?
Jack, I wonder if you would comment. You emphasize
We have a question.
you emphasize employment. And I wonder if you comment specifically that the task force explicitly supported the three-share concept.
We, and the issue of yeah, sure, let me put, the question is, can I comment about the important issue of the working uninsured and how the employers can help with that issue. And we do have some specific recommendations on that. One is centered around what's called the three-share program. This is a program which was piloted in Muskegon, Michigan. Is now, and Barbara Breyer from UTMB, who's been working throughout the state to get this implemented, says there's probably about 15 other states that have three-share programs now. The three-share means that there are three individuals or entities that share in the cost of the premium. The employer pays a third, the employee pays a third, and then there are federal matching monies or other matching monies available for the other third. And they're monies that can be legitimately accessed to provide that third share. The usual premium for each of the thirds is roughly $50 a month. The total cost is $150. We have spent a fair amount of time working with employers and employees to determine what health benefits are they interested in and willing to pay for. And all that spade work has been done. There's a lot of interest throughout the state in having this program. It shows an interest among, I think, small employers, and the majority, if not all these individuals are small employees, 50 employees or fewer. But shows the interest and the commitment on behalf of employees to address this issue. So we think it is a unique, an interesting way to provide health insurance for a large segment of the uninsured and at least get them some basic health benefits that they need. Yes.
Yes, I'm Tom Granchi. I'm a surgeon at Baylor College of Medicine. I also got my MBA here at Rice a few years ago, so I'm a physician and I know a bit about economics and business. And I've been struggling with this because I'm the medical director of the Ben Taub Emergency Room. From those of you from Austin, that's the Breckenridge. From Dallas, it's Parkland. And I have a couple of comments. First, because of the experience with socialized systems in Canada and England, simply making healthcare or making insurance universal doesn't guarantee access. We still have long waiting lines, and we have that at Ben Taub. I think the other issue is the people that consume it really aren't the payers, so there's subsidies both to demand side with overutilization and to the supply side with really inefficient care. There's very inefficient health care by all providers. And I guess the general question, 50 years ago, health care in this country was affordable out of pocket to the middle class. Why is that no longer true?
Well, let me address your first points about the need for improving how healthcare is delivered. The fact that simply making a universal insurance available doesn't guarantee universal access. All that's true. And all this was discussed by the committee, and we agree 100% with you. If we simply said that we have to provide access or insurance for all the uninsured, and that by itself is sufficient, we didn't say that. We weren't that naive. We understand that by itself is not sufficient. You need to address issues on the provider side. You need to address issues related to the whole health system side. So there are many, many different parts to the access issue. Having insurance is one that we think is a very important one, and we think is a very necessary one, but necessary, but not by itself sufficient. So we agree with you there. What happened to the cost of healthcare? That goes beyond our report. But as you know, technology, dramatic impact on the cost of healthcare.
Suggests that in other industries, technology actually drives down the cost of providing the service, and cars are better now than they've ever been, and they're still affordable. The printing press made books a hell of a lot cheaper.
But not true yet in healthcare.
Well, I think many times when people talk about the cost, they're actually talking about the charges and not the actual cost of delivering service.
But okay, let's just say that technology is one of the reasons why healthcare costs are high.
I think that's a ruse.
Okay.
As
well,
an insider.
Well, we can discuss that later on.
Okay.
Any other comments on the report? Yes.
Thanks for a great presentation. I have a couple of questions.
Sure.
Number one, could you address what Massachusetts is doing right now to use this coverage? And number two, maybe I missed it in the report, but I didn't see anything about the issue of undocumented aliens and their impact on healthcare, particularly emergency healthcare.
Well, let me work backwards. The committee did discuss the issue of undocumented immigrants, and all the information we can get, information from within the state of Texas, as well as information from those who have looked at this from outside the state of Texas, is it's relatively small. Anywhere from 18 to 24% of the uninsured are undocumented aliens, so roughly 20%. So it is a portion of the uninsured are undocumented aliens, but if you simply fix that, you still have 80% of the problem. So that by itself, it shouldn't be a focus. Now, the other issue you raised had to do with, Massachusetts. Well, first of all, let me just say that we applaud the state of Massachusetts and other states for coming forward with initiatives to address the issue, because it means that they understand the importance of that issue to their state. Whether Massachusetts, in fact, will actually eventually get implemented remains to be determined. In fact, and whether it will have the impact that is hoped remains to be determined, and we will look at that with great interest. Remember, in Massachusetts, the proportion of uninsured is far, far lower than the state of Texas, and actually is far lower than the national average. So they're starting off at a relatively low base. What works in Massachusetts may not work in Mississippi, may not work in Texas, but what is, from my point of view, is good about Massachusetts and Maryland, irrespective of what you think about their plans, is they're wrestling with the issue, they're having the debates and the discussions, and that's healthy.
Let me suggest that we bring Dr. Stoba back up here when the panel is here, but I don't want him to get all the really great questions and deprive our panelists. So please thank Dr. Stoba. Thank you, Jack. So next on our program is the panel of experts, individuals who are also experts in this important area on issues of health insurance in the state of Texas. And to introduce and moderate the panel this evening, we're most fortunate to have Dr. Kenneth Shine, the Executive Vice Chancellor for Health Affairs at the University of Texas System. He also served as Senior Advisor to the committee. As Executive Vice Chancellor, Ken Shine is responsible for the 6 University of Texas System health components and their aggregate operating budget. An eminent cardiologist and physiologist, Ken Shine is the former president of the Institute of Medicine, one of the nation's 3 national academies I mentioned earlier, where he addressed important issues of medicine and healthcare, such as the quality of care and the patient safety, nutrition, food safety, child development, and such matters. He is Professor of Medicine Emeritus. Emeritus has a nice ring to it, doesn't it? At the University of California, at Los Angeles School of Medicine, is former Dean and Provost of Medical Sciences at UCLA, received his bachelor's degree from that Rice of the Northeast, Harvard University, and his MD from Harvard Medical School. It's been an honor to work with Ken these past few years. Although it took him some time to make his way to Texas, the important thing, he's here now with us, working these important issues, not only to improve, working to improve the quality of the University of Texas Health Science Centers, already great in the world, but also by engaging many other important issues in our state, particularly in the area of health and medicine. Please welcome our good colleague, Dr. Ken Shine.
Could I get our panelists to come forward and sit in the appropriate seats? I don't know if you know this, but their names are on both sides of those placards. If you've ever been in a panel, you can never tell where they want you to sit. The bios of our panelists are in your brochure, and so I won't read them in enormous detail. I'll just remind you that immediately to my left is Vivian Ho, who's fellow in health economics in the Baker Institute, and she has the distinction of having received her AB in economics from Harvard. But she also has a graduate diploma in economics from the Australian National University and a PhD in economics from Stanford. Elena Marks is sitting next to her. She currently is the Director of Health Policy at the Office of the Mayor of the City of Houston. She received her undergraduate degree from Emory and her JD with honors from the University of Texas Law School, and an MPH from the University of Texas School of Public Health. Mike McKinney, who's sitting third over, is the Senior Executive Vice President and Chief Operating Officer at UT Houston. He was formerly Vice Chancellor for Health Affairs at UT, and he's had a very distinguished career, which has included serving as Texas Commissioner of Health and Human Services and Medical Director of an insurance company. Next to him is John Mendelson, whom I think you all know as President of the University of Texas MD Anderson Cancer Center, one of the, we would argue, the top cancer center in the world. Some people argue that by 1/100th of a point it's second, but we don't buy that. And John is also a very distinguished scientist and a member of the Institute of Medicine of the National Academy. There are several members of the task force in the room as well. I see David Warner here, Betsy Schwartz I saw earlier, Hector Baltazar, and there may be others that I've missed. So in the course of the discussion, if there are questions that come up that we think members of the task force might help with, we'd like to do that. Clearly, the Jack Stobo was able to hit, if you will, some of the major themes in terms of the recommendations, and not necessarily get into all of the interstices, which we hope people will take a look at with greater detail. But I thought we'd start by asking the panelists to just go, starting with Professor Ho, their reactions and the issues that they would like to raise, and then perhaps I'll have some more specific questions, and then we'll throw the discussion open to the audience and have hopefully an interchange. Would you like to say anything, Vivian, at this point?
Sure, I'll start things off. First of all, I think this is an excellent report, very comprehensive, a lot of very strong recommendations, and I think the committee should be congratulated on that. Let me comment from the perspective as an economist, which is why I'm on this panel. Where one could go from here, if you notice when you read the recommendations, there are actually no price tags on the various different proposals and recommendations. And I think probably if we actually tallied the total cost of everything that's recommended in the report, it would be extremely expensive, and unfortunately probably more than the Texas public is willing to pay for at this point. So one thing going forward would be to go through these proposals and take a good hard look and figure out which are the most cost-effective interventions. And by that I don't mean the cheapest, but I mean which ones are going to give us the most health for the reasonable amount of dollars spent. There will need to be a little bit more attention to some of the details. Let me give one example. The quality assurance tax, which was a 3% tax on healthcare providers. If you take this from the perspective of a public finance economist, what happens with these 3% taxes is they don't necessarily get borne by the person that you're actually taxing. What actually these depend on is elasticity of demand. So, for example, if you put this tax on some of our highest quality healthcare providers in the Texas Medical Center, they face very inelastic demand. And so what will happen is the insurance companies and the patients who go towards those institutions for healthcare will end up bearing that 3% tax, not necessarily the hospitals themselves. If there's elastic demand by other providers, well, then the providers are going to bear the cost, but then one is worried about how they're actually going to come up with that 3%. And to the extent they take that 3% bite out of uncompensated care that they're currently providing, there's going to be problems. So I'm not necessarily saying that is a poor recommendation, but it requires some closer look to see what is actually going on in terms of the economics. The other thing, the task force was assigned with just looking at healthcare in Texas, and I think once we get into the broader discussion, we'll have to be thinking in terms of how do we balance our money, in terms of whether we should be spending more in terms of education for children in Texas versus healthcare, and also at the federal perspective, what we should do in terms of complementing what's going on in terms of Texas with what's going on at the federal level. And there are many interesting things that are going on at the federal level in terms of electronic health records, which will complement what's going on with this particular report. But also, I think there's other things that are being investigated by CMS, for example, pay for performance types of proposals, which may be quite effective in Texas as well, and perhaps more effective than some of the things we've seen. For example, there are current CMS studies showing that disease management doesn't always work the way you would hope it would, and sometimes it ends up costing more and not necessarily leading to better health care. I'll leave it at that.
Thank you very much, Vivian. Elena?
I hesitate to say this on the heels of an economist, but I think the amount that is spent in this country on health care is ample to do what needs to be done, and it's a question of where you spend the money and not whether the money is there and whether we'd have to take it from another sector. From the perspective of local government, I'm pleased to see this raising itself up to the state level. And as someone who has worked with many people in this room on these issues for the last 2 years, we are constantly constrained in what we can do because of the numbers and because of the frankly limited ability of local government, city or county local government, and even regional government to a certain extent to affect the kind of changes that you have to have in order to make the systemic changes that you're advocating for in this. So I hope that this will be not a report that gets put away, but that spreads the word everywhere it needs to go and forces everybody to look upward and not continue to look downward for solutions at the local level where we have constraints, and I don't just mean financial ones. So I'm glad of that.
Thank you. Mike McKinney?
Sir. Well, about every 10 years we do a study, and this is the third task force that I've sat on. Hopefully it is the last. What we did decide was that we weren't going to issue pablum. It was going to have some substance to it. It was going to say what we meant to say and to figure out how to pay for it. And we didn't put how much it costs because there were too many zeros. But it is an expensive proposition. The other thing that we discussed that we decided not to put in the report was how much it costs not to do this in terms of economic development, in terms of education, lost opportunity from people with poor health, and frankly the cost to all of the rest of us who do have insurance and pay premiums and pay for the health care. So it is an economic study that perhaps needs to take place, but the investment in terms of covering the uninsured, it's important. There is I would say enough funds. We spend so much money on healthcare anyway. I think there's probably plenty of funds, but the maldistribution of those funds is something that we're going to have to look at. One of the things that was very important in terms of the the provider tax, the 3% provider tax. It was, that was a long discussion. It was a heated discussion. It was I assume that was probably the one where we had a negative vote. But in looking at the health care for the indigents, for the uninsured, as provided in Harris County specifically, there are a number of so-called nonprofits, and there are a number of for-profits, and there are a number of privately owned surgery centers that don't participate in the process. The idea was to this is a societal problem. This is not a problem of the doctors, even though they treat them when they show up in the emergency room. It's not a problem of the hospitals, even though they provide their services when they show up in the emergency room. It is a societal obligation and a societal problem, and that to continue to allow some hospitals, some providers to reap the benefits, the largesse of a system that pays for some and doesn't pay for others didn't seem fair. And the intent was to provide for some tax deductions or allowables against whatever charity care is already provided by individuals or by these hospitals. But it was an attempt to have everybody participate in the process and frankly not to allow skimming, or at least not to allow any more than 97% skimming. We also we all know this, but acknowledged that this is a national issue, and it requires some national solutions. It is too complicated for regional or local funding. We would like to see, first off, the national Congress and the policymakers address some of the issues, but we think it requires a statewide funding system, not just local taxpayers, not Harris County. Everybody's a taxpayer and everybody's local, but not an ad valorem tax collected in Harris County or by the city of Houston or somebody else. An equalized statewide taxing system with regional delivery. Do I think this solves all the problems? No. But I think if implemented, I think it would improve the health and the future of the state of Texas tremendously, and I think that there won't need to be another task force for maybe 15 years this time.
Don Mendelson?
I think my fellow panel members have covered a lot of the issues, so I'll just amplify on one that they haven't mentioned, and that is we're going to need a central command to do this. We're going to need a group of individuals with quasi-governmental powers to select among the various priorities that have been proposed and to enforce participation by all providers. I think Mike put it very well. There are counties around all the big cities in Texas that take advantage of the fact that in the big cities there are large hospitals, such as Ben Taub, as was mentioned, that service these patients and dump their patients on the big cities. It really wasn't addressed. That I haven't read the whole report. I only got to see the summary ahead of time, and maybe it's in there. But I think this is where this is going to be put together. And as Vivian said, we're going to have to pick priorities, and we can't have unfunded mandates. So somebody's got to work out money transfers. Where that central command sits, who's on it, who they're accountable to, is sadly, but correctly, a very important issue that we'll have to address having received this wonderful report. My main point is to congratulate this group. You're shining a very, very bright spotlight on issues that most of us know about, and anyone in the health field knows about it, but I don't think it's enough public attention, and I want to thank the people that did this for doing this terrific job.
Thanks, John. The report is rich in examples of what has been done in many of our communities. Right in this community, the the experiments with cash-only ambulatory facilities that the Herman system is doing, the fact that the Seton system has in fact had an electronic way of tracking people who are indigent and come to one or another sites, as Jack pointed out. So I think that we should recognize that with all of the concerns that we have, that there are real efforts being made with LifeLink in San Antonio and a variety of other. We tend to want to shine the light principally on the major challenges, but there were some hopeful bits of information, and the commission papers include some examples of these successful programs that we think people should build on. I do want to emphasize that someone raised a question about the difference between health insurance and access. Our number one recommendation does not say everybody should have health insurance. It says everybody should have access. And we recognize that in a state like Texas, there will be complex ways at which access is available, and some of it will be through a real insurance program, but there are other strategies which are discussed in terms of community-based ambulatory care and so forth, which are relevant. I do have to take issue with the comment about technology. 25 to 50% of American healthcare costs are associated, inflation in healthcare is associated with new technology. And it is paradoxical because in almost every other industry, technology lowers costs. We have a wonderful system in the healthcare system, and that is we know how to make up in volume what we lose in price. For example, fiber optic cholecystectomy can be done at somewhere of the order of 40% of the cost of a laparotomy, that is opening up the belly. But if you look at institutions that do those, you find that total costs rise because they simply do more of them. If you think about the marvelous surgery for the cataracts, the prices come down, down, down. The technology has gotten better, so we do more and more and more. And particularly under a circumstance in which a third party is paying for that, that becomes a tremendous driver in terms of cost. And it's one that we've not been willing to make very hard decisions about in terms of the way in which we use that new technology. I do want to give, before we open things up for questions, I do want to give David Warner an opportunity to just comment for a moment on this 3% assurance fee, because in fact it is complex as to how the money works. And I think it is worthwhile perhaps to have David remind us that that in fact what this money does is it provides more Medicaid funds, but what the implication of more Medicaid funds are.
Right. I think the crisis, one of the crises that we identified was that especially in cities like Houston and Austin, and really in the whole state, both the cuts that occurred in 2003 and some of the demographic changes have left the system way beyond the capacity of local taxing authorities. That in Houston, Chuck Begley tells me there's 1 million uninsured in Harris County, and the tax rate currently is about, I think, 24% per $100 just for the hospital district, and what is the right number? I don't know. 19 cents. But I think it's around $400 million is what that generates. And across the state, it's around 1.2 to 1.2 billion that the various hospital districts are currently gathering in just local unmatched money. Now, they're able to match some of that money, but probably less than half of it through disproportionate share and other things. And with the disproportionate share funds are really the only money which you could do some of these experiments with. But because the Medicaid rates are so low and because of such a high number of uninsured people, basically all of the dispro funds that's available other than to the state is going just to not make whole, but at least get some of these safety net facilities up to a point where they can continue to function. and they're shifting to those who can pay. So I think our idea was, okay, I mean, it would be simple for us to go to the legislature and say, the legislature should just give the system another $2 or $3 billion, and then we could expand Medicaid. It was pretty clear the legislature was saying that they didn't want us to just say that. This is a mechanism which is possible, in which most other states do, which is to have this kind of quality adjustment fee. So you'd have the 3% fee, which would bring in 1.1 to 1.2 billion in general revenue, draw down another 1.8 billion from the federal government. The kind of miraculous thing about something like this, if that whole 3 billion you turn around and just spend on Medicaid expansion, either by increasing rates, by replacing the spend down, so you can spend down eligibility, and cover people up to 100% of poverty who live in families at about a 50 to 60% benefit package. And it still might fall a little short, but do those things. What you would do is you'd then free up some of the local tax money to do other things and the disproportionate share money. And some districts might even be able to reduce local property taxes a little bit and maybe not have to increase taxes in the future as much as they're going to, just to keep things going. So our idea behind this was to do that. There was another piece which is also in the report that says we think that all counties should have an obligation up to 100% of poverty for indigent care, and that they should spend at least 8% of their general tax revenues. Currently, it's at 21% of poverty, and they only have to spend up to 8%. After that, there's a state fund that comes in. But if you have a hospital district, that's a different story. This is for counties that don't have hospital districts. So our idea was that this, working in concert with at least a modest expansion of Medicaid for family members up to 100% with that this all would fit together in a way. And so that was the idea. And the idea was that extra revenue would then, well, that in any case you'd want to do the virtual kind of medical record approach and some of these other things that would make things more efficient and make sure that people in the most need were getting care. But also the idea is that if you would free up some of the disproportionate share money, that could go into 3-share that could cover low-income workers along with their own contribution and businesses' contribution. So that was kind of probably an overly lengthy. Yeah.
Right. Thank you. I think, Mike, you made some reference to who does what in terms of providing care, and we've made reference to the fact that we see that one of the major dilemmas in Texas is this county-based system, and we make some recommendations about regionalization. I wondered if you would comment about how and what way one might think about regionalization.
Yeah, first off, we probably have to look at the way healthcare is actually delivered, and it is delivered on a regional basis. And people from Montgomery County come down Fannin Street every single day, and just looking at this area, it is delivered on a regional basis, and pricing is really on a regional basis. We talked about on multi-county hospital districts. There's that possibility, but then again, you're back to ad valorem taxes. We talked about organizing the delivery system along a regional basis, as opposed to the taxing. We think the taxing is probably going to have to be statewide. There's going to have to be some uniformity to it, but that the delivery could be organized along either public health districts that we have, or even better, the existing, not trauma districts, but the trauma systems that exist in the state right now. If you could have delivery systems for health care, from primary care, secondary care, tertiary care, or whatever, all the way along the lines of the trauma system, you would have built-in referrals. You're still going to have what Dr. Mendelson was talking about. You're going to have somebody who's in charge of writing the checks. But again, we think that it's better on a regional basis in terms of healthcare delivery, as opposed to right now it's financed on a regional basis. So there's a lot, not even on a regional basis, financed on local, and it's delivered local, regional, state, national. We just think there needs to be some uniformity to it.
As somebody who worries a lot about the Harris County or the city of Houston, does it make any sense to try regional approaches, Elena?
Absolutely. You get the numbers up, and you can do a lot more things when you have larger numbers of people. And as Mike said, they're already part of the same system anyway. I can tell you from the EMS perspective, watching where people come from, where they go to, watching what hospitals do, whether they let people in and who they let in, it's a much broader problem. And being able to group a larger number of people and acknowledge that and generate resources that are meant to account for all of them, you could probably do a lot more with the same amount of money.
One of the things that the task force pointed out was that the ratio of federally qualified health centers per population continues to be very low in Texas compared to other populous states, California, New York, Chicago, and so forth. You've recently had some success in Houston with some additional federally qualified health centers, and HRSA has sort of been ambivalent about what it was going to do in the future. Now looks as if there may very well be some resources with regard to federally qualified health centers. Do you have any observations about the potential for such centers and or what the challenges are in terms of making them work effectively, what the relationships ought to be between community and health providers? We talk about, for example, increasing the number of medical residents in the state because we think that they ought to spend more time at ambulatory centers that are community-based, perhaps at federally qualified health centers. Any thoughts about the future of these entities? Eleanor?
What we've been told by HRSA is that there will be no more new starts, so we are where we're going to be for the time being, that the program is funded enough to continue funding for existing centers, and that they will allow new centers to be designated as lookalikes, but they won't get the grant and they don't get the Federal Tort Claims Act coverage, which means they have to have med-mal insurance. And that's a pretty big handicap for a startup organization. The problem that our FQHCs have here, in addition to just plain old being brand new, is that the Medicaid program is so poor in Texas that you don't have the opportunity to maximize the revenue enhancement that Medicaid gives you, because we just don't have the Medicaid patients. And for the FQHCs to be successful in the long run, they need that kind of a funding stream. Ours are depending substantially on fee-for-service and philanthropy, and those are great assets, but the way the program is really designed is to build on a Medicaid and Medicare population, and we are handicapped compared to other states because we have such a small Medicaid program. I still think we ought to be trying to get more FQHCs designated, even if they're just look-alike, because there are more advantages to having it generally than not. But it's not the answer, and we've seen that with ours. We've had one open and close in a 6-month period of time. It's one very small piece of the puzzle.
I think we now throw the panel open for, I'm not going to throw the panel anywhere, but I'd like to have an opportunity for questions. And Jack, you want to come up as well? And they've put a fancy chair at the end there for you. And so we're open to slings, arrows, outrage. Yes, sir, please. Would you just identify yourselves just so we know who you are?
I'm Bobby McMillan. I'm a student at Baylor College of Medicine. You've already mentioned things like statewide taxes and more central administration. I was wondering if you considered something like sort of a statewide universal healthcare system, like a single payer, as it might relate to saving money by eliminating the need for marketing, less administrative costs, larger risk pools, and saving money by providing actual, more than just simple access, but actual care to the uninsured, so that you would decrease decrease the cost and complications, like complicated births, by providing prenatal care before birth?
Thank you. The question has to do with a single payer or something similar to that. Jack, do you want to try to field that?
Well, we didn't, as far as I recall, we didn't say anything about a single payer. As Mike McKinney said, that other than to point out that the current county-based system is fragmented and inequitable, we really didn't have a lot of details on how a larger system could be put together, a regional or a statewide system. So no, we don't have a lot of those details. But the points you raise are ones that we hope that will be considered. We hope that if the recommendation is seriously considered, the issues that you are raising will be part of the discussion and will result in a better system.
Anyone else want to comment on single payers? Yes, Dr. O.
I think a recent book that's come out by David Cutler, who's a health economist at Harvard University, talks about this issue very effectively and about the issue about technology as well. But one of the things he points out is that the rate of increase in healthcare costs is just as high in Canada as it is in the US. So perhaps we can save a little bit of money at a one-time shot by moving to a system like that, but it's not going to solve the problem in the long run. And in addition, when you talk about problems in terms of, yes, we've got a lot of administrative inefficiencies, which create a lot of healthcare costs, but I think one of the nice things the panel recommended is to try and identify things within the US healthcare system like uniform electronic health records that are going to save us costs in the long run. It's going to be a little bit more expensive, but I think there's also, we could go have a long debate, but there's also a number of people who believe that despite some problems we have in terms of preventive health care, Americans would vote for the U.S. healthcare system overall over the Canadian if given the choice.
I just comment that I think that there actually have been surveys in which Americans have preferred some more of a tax-based Canadian styles.
Yeah, actually the polls are very interesting. Your point is very well taken. If you ask Americans, is the healthcare system broken, they will generally agree. If you ask them whether it should be fixed and whether, for example, a single payer would be useful, they will generally agree. If you ask them whether they're willing to accept a change in the way their personal health care is provided, they violently disagree. That is, there's a big dichotomy between what people say in polls about the system as a whole and their unwillingness to see the system change. And that's one of the challenges in terms of how you get policymakers, because policymakers are influenced by all of those individuals who say, don't change. I'm satisfied with my doctor and my access, so don't fiddle with that while you fix the rest of the system. That's a major issue, and one of the points of the report is to emphasize how, in fact, those individuals are being impacted by the fact that it's an inefficient system. So we take your point. Please, Sherry Martin.
Sherry Martin. I'm the Vice President of Process Improvement at MD Anderson Cancer Center, and I also chair the Texas Hospital Association Committee on Quality and Safety. I first want to applaud Mr. Lane and the task force because, as I understand it, America is the only nation that does not provide universal access for health care to all citizens. So I think it's wonderful that you took this on. My question is actually initially, I guess, to the task force members. One of the questions from the audience alluded to the issue that healthcare in America is supply-driven, and Dr. Shine just commented that we have been unable to, in some way, manage underuse and overuse of procedures, treatments, and diagnostic procedures throughout the nation. Did the task force consider restricting healthcare? That is, establishing criteria to restrict procedures or treatments for specific populations.
You want to comment, Mike?
I will, yep.
Dr. McKinney?
We now we ration by inconvenience. We've already done that. And so what we talked about was, in fact, we looked at the Oregon system. We talked about whether or not we rank priorities and the needs and effectiveness of what we should do. So we talked about that particular piece of it, whether we didn't necessarily decide that was a good idea. Oregon made a big splash, frankly, in the savings and the procedures that they actually denied number was almost zero. So we did look at it, but didn't decide that that was a
Oregon
reasonable
did
approach.
disallow kidney dialysis, and everybody with kidney failure moved south to California at that time.
So it's inconvenience and Greyhound, have both of those work.
It's clearly a tough nut. My own view, Sherry, is that, and this goes a little bit beyond the report, is that one of the most effective ways of getting that situation addressed is through what I call shared patient-doctor decision-making, where the patient thoroughly understands their options. And if you look at Jack Wenberg's work, when you give patients all the information about their choices in treatment, for all but about one of the conditions, he looked at, I think, 14 conditions when he was doing these studies, patients, 40% of the time for each condition, opted for a less expensive or a less radical approach than their physicians recommended. Their physicians tended to recommend the most up-to-date technology, the most radical kind of treatment in terms of, and the patients voted 40% of the time not to do that. I personally believe that the more patients have that choice, the more they understand their options and can make good decisions, I think you'll find that there will be a certain amount of, quote, rationing under those circumstances. But it really requires adequate information. Please, I think you were up to next.
Thank you. My name is Ken Parsons, and my field is physical medicine and rehabilitation. So I'm from a highly specialized field within medicine. I've been focusing my attention today on recommendation 7 and its subsections. And I think, if you'll allow me, I've got a few comments that might be relevant. First of all, I think physician behavior may be part of the problem. I think it's also part of the solution. All of us here in Houston had to respond to one degree or another to the emergencies having to do with the hurricanes last year. And we saw the overwhelming response of physicians and other healthcare providers in this city who were able to respond to an emergency and stepped up in a wonderful way. Why is it in the culture of healthcare that we're not doing that routinely for these folks? I think there's some very real reasons for that. Probably don't have all those answers, but it certainly would be something worth looking at if there's further work to be done by the committee. Oh, I hesitate to say that because you folks have worked so hard already, but I think that you're really onto something when you look at the need to train more healthcare professionals. I would plead that you look at which healthcare professionals you need to train more of. Primary care physicians, yeah. Pediatricians, oh yeah. And obstetricians, because there's a decreasing access to good obstetrical care across the nation because of a whole lot of reasons that you're probably aware of. Secondly, the question has come up about new technology. I wholeheartedly agree that we need to have meaningful dialogue about whether new technology passes the so what test. Does it really make things better? You, Dr. Shine, you picked two examples that may be biased. One, cataracts in the aging population, and I haven't seen anything yet in here that talks about the aging of our population. And secondly, the problem of gallbladder disease, which is related to some obesity issues and other sorts of things. And secondly, I would say that healthcare professional teachers, as I've been for almost all of my career, need to be teaching their students, their residents, how to evaluate new technology and how to evaluate new drugs. My basic rule of thumb is I will not prescribe what's advertised on commercial TV because I think that there's way too much cost involved in that unless it's clearly better than the old drugs. In section 7.4, you made an excellent point about having more faculty to train more nurses. I think that's a wonderful idea. But what about training physicians? The faculty situation that I find myself in has no financial incentive for training physicians. As a matter of fact, disincentives because of the Medicare fraud investigations that sort of fell off the board after 9/11, but are now starting to come back again. And so when we look at training more healthcare physicians, we need to be looking at how we get more faculty. And finally, I would say with regard to 7.6, and the mandatory provision of services in an emergency room. If you come to the emergency room and I'm your physician and I'm a physical medicine and rehabilitation doctor, I hope you have back pain. Because if you're having an MI, I'm not the right doctor for you. So I think that should apply to physicians who have relevant specialties. And likewise, the incentives of paying off medical school debt should be incentivized to those who are going into the appropriate fields where the need is the greatest. California tried to do this. They were doing this at about the time I relocated to Texas, decreasing the number of specialized residency slots and increasing the PCP slots. Maybe that's something we need to look at here.
Actually, in the proposal with regard to loan forgiveness, it's based on service where the population that you serve is an underserved population, and we did tie that to where you work. I would just emphasize one, thank you for your comments. I thought all of them were very relevant. One thing I do want the audience to be clear on, there is clearly a physician shortage in the United States and in Texas. National organizations have recently recommended as many as a 30% increase in the number of physicians who are produced in our medical schools. In Texas, we have very limited number of residency positions. We have one residency position now for every graduate of medical school. That is, there are about 1,300 first-year residencies for 1,250 medical students, except that many of those medical students don't want to go into many of those specialties. We have only 2 emergency medicine training programs in the civilian sector in Texas. If you want an orthopedic residency, an anesthesia residency, 46% of Texans graduating from Texas medical schools go out of state for their residency. Now we're going to increase the number of medical students. Without more residencies, we're assuring that more of those students will go out of state, and 50% or so of them won't come back. So here we are investing our money in their education. And the most cost-effective way to increase the physician supply in Texas is increase the number of medical residencies. They cost less, they provide service, they could be working in ambulatory care situations and helping us with the uninsured. And I just want to emphasize that as part of the workforce issue. The nursing issue, it's all about faculty. There are some interesting experiments going on right now with nurses acting as preceptors, where registered nurses are supervised by faculty, and the results look very promising that we might get a multiplier effect in terms of students. Please.
Alma Rodriguez, and I'm Vice President of Medical Affairs at MD Anderson. And a couple of observations about, again, also recommendation 7, as I'm also concerned about graduate medical education. And I noticed that the recommendation only talks about physicians and nurses and ignores a segment of caregivers that, in my personal experience, are invaluable and that actually literally expand enormously the capability of and presence of physicians, and that's the mid-level providers. And if there are few positions for physicians in Texas, there are far fewer positions for physician assistant training slots and mid-level provider, that is advanced practice nurses. I would encourage that the panel look at a model of healthcare delivery that incorporates these individuals as essential for frontline care. We may not necessarily need any more physicians if we have a cadre of qualified individuals who can expand the delivery of care with the physician supervision and assistance. And I do applaud your efforts to reduce the debt, because in part that also drives, I believe, selection of residency programs as well as subspecialty training. We do need more primary care physicians, but salary in the marketplace is lowest for those providers that we need the most. So applaud you for that consideration, and which is required in this day where also federal funds for assistance to students has been declining. So thank you.
Thank you very much. Does anyone want to respond to that? I think the point, you are correct. We did not take a major look at mid-level providers, and they are critical, and we probably should have paid much more attention to that particular phenomenon. I do want to emphasize for the audience the point that you made about debt. The average medical student who graduates from a public institution in Texas graduates with a debt of $100,000. From a private institution, $135,000 across the country. In this state, it's a little bit less than that because of some state subsidies of the private sector. And this is particularly important because among certain segments of our population, and Hispanics are particularly vulnerable, they abhor debt. We see this in the undergraduate part of the University of Texas. Hispanic students that's why so many of them work and go to school, so they do not accumulate debt. Looking at those kinds of debt figures, you can see why we're having difficulty in increasing the number of Hispanics in our various schools. Please.
My name is Karen Gonzalez. I'm a registered nurse from deep South Texas. I've been practicing for over 20 years in Corpus Christi and the last 15 in the Rio Grande Valley. And I commend y'all for the work you've done on this, and I'm so glad that we're really looking at it, and maybe we can get some national attention as well and drive down the cost from the pharmaceutical companies and the Baxters and so forth and so on. My concern is the 3% tax on the providers. As a manager in the Valley, I have witnessed over the last 15 years the nurses going from double the patient load to triple the patient load because the hospitals are not making money every consecutive month. In fact, they are losing money every consecutive month. A big problem is the not documented workers, the fact that we are so close to Mexico, and so if she's in labor and can make it across the border, then she's going to have her baby in our hospital versus in Mexico. I mean, these are issues not for this panel, but I'm afraid that a 3% tax on an already hospital that's losing debt is going to be devastating to the nurses and make your shortage in the Valley even worse than it is now. And in fact, make your patient care even unsafer than it is now. And I would just beg that there would be some sort of evaluation with this 3%. And might I suggest that we look or work with the Texas Workforce Commission to identify those who are providing pay to the non-documented workers so that they are taxed as well for employing people and not having to pay taxes for the people they have employed. I have seen several severely injured young men come in and they say in Spanish they got hurt at work. Somebody comes in from their work and they say, I don't know who I was working for. They are trained not to identify who they are working for. And I think if we utilize the Texas Workforce Commission, we can hold them responsible and tax them as well and maybe save our patients with some safe nursing. Thank you.
Thank you very much. Does somebody want to comment with regard to, I think it's important to understand that the proposal for the quality assurance fee would in fact ultimately help those hospitals, because the whole concept behind it is that if you could draw down $1.50 for every dollar that is taxed, and then you reimburse the hospitals at higher rates, then they have a better chance of maintaining an income stream that's likely to in fact allow them to do their job better. The dilemma is that not all institutions would benefit, but the kinds of institutions you're talking about would in fact be major benefactors of a net increase in dollars based on what we're talking about.
Even though we have probably greater than 50% of non-paying clients that don't even qualify for Medicare?
There would clearly be a benefit in terms of payment, so that those people who were Medicaid, and they can be a relatively smaller proportion, are reimbursed much more effectively. Secondly, the pool of money now becomes substantially greater for Medicaid, and to the extent that that pool allows the use of disproportionate monies in a different way, you can in fact get a benefit. Now obviously it depends how the legislation is written, and I don't pretend for a minute that we're writing legislation. It depends critically how the whole plan is put together. But we think theoretically, at least, if it was properly administered, it could be beneficial. I think and that's what we're, if you will, trying to.
Maybe it might be beneficial to utilize a resource in the Rio Grande Valley because as being on the management team,
Sure.
I've been able to identify that I think there have been probably a large amount of every month we're probably looking at maybe 50 to 60% non-payers. They have no money. For instance, the man who's worked here undocumented for 30 years and now he's retired and he's in renal failure. And so we have to take him.
Right.
And we have him for 2 weeks. I mean, I think it would be beneficial to the entire state to include the severe issues we have in the valley.
Yeah, and we've worried a lot about those issues. One of the we got a lot of controversial recommendations. One of the controversial recommendations we made was that state and local government contracting with employers to do governmental projects in the scoring system to evaluate their bids, whether they cover their workers for health insurance should be considered as a significant part of the scoring process. We argue that you're using taxpayer dollars to pay for the construction or whatever you're doing, and that those employers, in fact, have a substantial number of the kind of patients that you describe who are not getting any insurance coverage, and when they get sick, the same community is now having to provide health care. Very controversial, but we'll be interested to see. It's not more controversial than Maryland's attempt to tax Walmart. Please.
My name is Rup Shah. I'm a student at Rice University, and I was just wondering what has prevented or discouraged Texas from taking more advantage of federal funds, such as the sharing of Medicaid, and how can these barriers be addressed?
Does anyone want to take on that?
The question was, why haven't they?
The question is, why hasn't Texas not taken more advantage of matching money from Medicaid? I mean, just to give you one example that, seemed to us counterproductive, was that there was a Medicaid fund. You can fund graduate medical education residents through Medicaid. By lowering the amount of money spent by the state by $20 million, the federal match was lost, and we lost $50 million. So, in fact, in a tight budget situation, it's a serious problem. Hopefully the state may be over the next few years in a somewhat better situation, but I can't speak for legislators in terms of why it's been so difficult. It's just been very difficult. Over here, please.
Yes, I was wondering if anyone on the task force or any of the panelists have any idea about what the effects of tort reform would be on reducing costs to medical systems, because I know private practices in non-tort reform law states have increased the amount of insurance payments by somewhere between 200 and 300% in certain specialties, and non-tort reforms or tort reform states such as Mississippi, the price of insurance has really gone down quite a bit. So I wonder if you could comment about that.
Anyone want to comment? Please, Dr. Ho.
I think the most the studies of major reforms across states took place in the mid-1990s, looking at different states which had more restrictive caps on tort reform. And what they found is that overall, if you sort of combine all the different types of things that were done to limit medical malpractice suits, you saved $57 billion, which at first sounds very large, but it's a drop in the bucket compared to total healthcare costs. So in a way it sounds nice, but it's not going to solve our healthcare cost problems.
It is clear Texas passed tort reform in 2003. Is that right? I got the year right? There's been a significant decrease in the number of claims filed as a consequence of that. The University of Texas has its own liability coverage. I can tell you that after an upsurge in the claims just before the law was changed, we've seen a progressive decline so that the number of claims is of the order of half of what they were before. And there has been some improvement in premiums. And in fact, it's been argued, and this, I rely on Dr. Ho for an economic analysis, it's been argued that the return of neurosurgeons and some OBs to Texas was a reflection of that, because even though it's a drop in the bucket for the whole healthcare system, for a particular neurosurgeon or obstetrician, it's a significant expense. What we are balancing is how do you, in fact, act fairly to patients who do have a legitimate reason for getting a much larger award. And because the awards are capped at the level they are, it appears that tort lawyers are taking on many fewer clients. And the question is, in the balance of that, is that totally fair to patients? But the fact is the claims are dropping and that premiums, in fact, are declining in Texas since there were tort reform here. Please, I guess this is the last question.
Given, also, I don't know if this is another just drop in the bucket or how much of a drop it might be, but given that the practice of defensive medicine is a huge driving force behind the technological imperative and the disproportionate spending on high-cost technology, I was wondering if there was any thought given by the panel, I haven't had time to read the whole summary yet, or if the panelists could comment on, is the trend in that area still increasing, and is there any way to protect the healthcare decision makers from making costs that benefit the community or the state as opposed to benefiting a few people using high-cost technology?
Thank you. Good question. Who would like to try that? Mike?
In educating the next generation of physicians, one of the things that we try to emphasize is, if you're going to bill for a history and physical, do a good one. And one of the things that you will find by doing a good history and physical is you will be able to better focus what expensive tests you need to do, what expensive tests you need to repeat. I will say that from our perspective, the practice of defensive medicine has been overstated. I think that we try to encourage the past generation and the next generation both. Don't do a test if you don't know what you're going to do with the results. And so I think that that there is a little bit more comfort in not doing a test, just to have a document in the chart that says this was what was wrong. If you know what's wrong from a history and a physical, write that down, treat it that way. So I would say that defensive medicine has decreased some. Probably should have never been an issue, but frankly, people don't take kindly to having their future and their children's future threatened. So in terms of decreased health care, I can't tell you, and I can't tell you about the premiums. They may have gone down some, but in the field of the need for defensive medicine, I think there has been a decrease, partly based on some protection.
Dr. Mendelson looks like his brow is furrowed.
I agree with what Mike said. I don't think the issue is defensive medicine. I think the issue is offensive medicine. If you've had head trauma in an automobile accident, you come to the emergency room and your physical exam is normal, but there's a big bump in the back there. Do you order an $800 CAT scan or not? Or an MRI, which could detect maybe one chance in 200 there's an internal bleed that might cause trouble. The American public, including everyone in this room that wishes we had a uniform medical care system but don't change the way we're treated, want that MRI scan before they leave the emergency room. And that's why healthcare is more expensive. The technology has allowed us to zero down and look at very improbable but still important to you and me if we've had the head trauma issues, and you have to pay for that. And it's silly to hide the issue. A lot of what we spend at MD Anderson taking care of cancer patients could be avoided if they're willing to say, well, my chance of living 5 years is so-and-so, but if you do this test, I might have a little more chance. They'll do it. If giving chemotherapy after a breast resection can reduce the risk of recurrence 2%, most women will say, give me that chemotherapy for 6 months, which costs thousands of dollars plus the side effects. But they want that extra 2%. So the problem is that we've got very high standards for ourselves in healthcare. And of course, this 40 million people that are uninsured don't get to participate at all. So it's totally unfair.
Jack, you want to make any comment?
Well, I was just going to add, particularly when most of those individuals themselves don't have to pay for that test.
Dr. Ho, that was an economist's statement. Do you want
Well, I think it's the other side of what we haven't talked about, and that is a lot of the ills that we're discussing is because of the health insurance program we have in the United States.
Yeah, I think one of the areas that the report deals with is the so-called EMTALA situation, which is the emergency treatment and labor laws that require patients seen in emergency rooms to be fully evaluated. We think that there's room for much more flexibility as long as you're able to offer a rapid ambulatory assessment of that patient so that you in fact don't put the patient through a whole series of very expensive kinds of interventions at that time, which most physicians feel they must do because of that very small but finite risk that they'll send out a patient from that emergency room and something will happen which will be not good, and the damage to the patient and to the institution and the physician is substantial. So finding ways to increase the efficiency of care so that you're not putting people through an extensive emergency room process when in fact an ambulatory process would do is one of the areas that we explore in the report that you might be interested in.
I just had a question about the report addresses a lot of basic causes which would involve long-term solutions. What are some immediate strategies that could be used, such as like education or encouraging alterations in physician practices? Would those make any difference in the short term, and are they worth investing in?
Anyone want to comment with regard to that question? It's a very good question and important.
It's a very good question, and I think education wrapped up with accountability is important. Just taking our field, cancer. If everybody quit smoking and had the checkups that are suggested and kept trim and ate well, we could cut cancer deaths by 50% with no more research and no more emergency rooms. So the American public, part of the issue, and I deal with it when I'm thinking about how to improve cancer cure rates, but part of the issue is don't drive when you're drunk, don't smoke, and just follow the rules that we all know make sense, and we could save a fortune on health care. And the American public someday has to be held accountable to do that, in my opinion. And I don't know how to encourage it. It's a huge issue.
There are 2 or 3 items in the report that are directly related to your question. One, people need to be able to get information quickly about where to get their care. And we cite the experience at the Breckenridge Hospital in Austin, where they have a 24/7 telephone line in which people can call and find out where's the best way to get care for whatever that bothers them. 62% of the patients who use that telephone line do not go to the emergency room. They're cared for elsewhere. Secondly, there have been some very interesting studies showing that when you look at people who are either new to a community or have language problems or whatever, they will know where the emergency room is locally. They will not know where ambulatory facilities are. And so making real attempts to help people understand what their options are is important. And thirdly, we have a whole chapter on the relation of education to health. And we deliberately focused on that because A, there is very clear evidence in this country, and in fact with the exception of 2 countries in other parts of the world, throughout the world, the higher you are up on this socioeconomic ladder and the educational ladder, the better your health. And conversely, the lower you are in the socioeconomic educational ladder, the poorer your health. There's a very close relationship. Secondly, we make strong recommendations with regard to programs to improve health, including disease management of such issues as asthma, which have been shown clearly to allow kids to go to school more frequently and to participate in education. And finally, we make strong recommendations with regard to improving health education in the schools. That's where youngsters begin to learn how to deal with health. You may be interested that Charles Lewis showed years ago that if you looked at a playground and you watched the behavior of kids who were 5 to 8 years old, 7, 8-year-old kids, you could predict their health behavior by what they did in response to a scrape or an injury. There were individuals who simply got up, kept doing what they're doing, and denied that anything was wrong. There were others who immediately wanted care and acted out in a variety of ways to get attention. That pattern exists they were followed for decades. That pattern persisted through life. So some of these attitudes about health and so forth are critically important. And we also make strong recommendations about exercise in the public schools. We're very pleased with Susan Cohn's work to improve food availability in the schools. But all of this is part of the education that you speak of, which is absolutely essential. And we think that they're debating education reform in the legislature. They also should be connecting that to improving health. And finally, there have been some interesting experiments in South Texas, as a matter of fact, showing that if you could provide better health and prevention of illness, the enrollment in the school goes up because average attendance increases, and they draw down more state money for education. So there's actually an economic benefit from having a healthy bunch of school kids. You've been very patient. We appreciate very much your being with us. We anticipate trying to disseminate these ideas. We know that they're not going to be easily accepted in a number of arenas, but we feel that it's critically important that there be a discussion, and a major discussion in this state over the next year about these issues, and we welcome the opportunity to be able to discuss some of the ideas with you. With that, I'll ask Dr. Lane if he has any final words of wisdom before we adjourn. And I want to thank our panel for their willingness to participate.
Well, on the behalf of the Baker Institute, I want to thank our panel as well, and Ken Shine for doing such an excellent job of moderating, and all of you for being with us this evening. What I didn't say in the beginning is that we all served on the task force as individuals. That got said several times, but of course the report does not necessarily represent the views of Rice University or the Baker Institute, even though I want to go on record saying we're for good health for everybody. Thank you all this evening. Have a nice evening.